the H we're recording. The helmet is deeper. So essentially it can target deeper structures or activate deeper structures, whereas the 8 coil is believed to be more superficial. And then the site that you target. So in a lot of treatments, you see the targeting of the dorsolateral prefrontal cortex, specifically the left side. And we're trying to activate that to increase executive functioning as one of the brain circuits. So, but you could target other areas. So there's different research targeting the medial prefrontal cortex, depending like the anterior cingulate cortex, which are all different weird terms, but depends on the disease that you're targeting. So how does it work? So thinking now about, so we talked about the coils, now talk in the site, talking about intensity. So what dose we deliver, so what is based on your resting motor potential. So we essentially bind your cortex, we deliver a stimulus, and we look at the minimum amount that will cause a contraction in your muscle, usually the thumb. And we just look visually. You could do it on EMG, but we just do it just by looking. And then we usually, in typical protocols, you deliver 110 to 120% of that to the target region. If you go higher than that, you're more likely to induce a seizure. So that's why they, like at 130, it's not within, like if you went above to 130%, it's not as safe. So, and then the pulsating magnetic field is done in different frequencies, so different pulses. So it could be like high frequency, which they believe at like 5 hertz to 10 hertz will actually increase the activity of the brain tissue below the coil. And then low frequency will decrease the activity. So you might think, and we'll talk about it in a second, but you might want to increase different activity in different areas of the brain, right? So like executive control would be more appropriate to be stimulated or increase the activity in that circuit. And other ones where you're maybe seeking like impulsivity or other things you want to decrease the activity. So the pattern that we deliver it, we do it in continuous, intermittent, or theta burst. I won't go into much detail. So in terms of the FDA or Health Canada approved indications, so it is approved and is being used for treatment-resistant depression. You can go to private clinics for this, and UBC has one. Also treatment-resistant OCD. The targets between those are different, but again, we're not a rheuma psychiatrist, so I won't go through that. And then it is actually approved for nicotine use disorder. Emerging indications, so bipolar depression, PTSD, which I think is kind of important for our patient population. Like in Powell River, they're using it with people with comorbid PTSD, even though it's not approved at this time. And then other substance use disorders, there's a lot of emerging research around that. In neurology, there's some emerging evidence about post-stroke rehabilitation, mild cognitive impairment, which is a key contrast to ECT, which like affects cognition. This one, they think it can improve it, right? And then Parkinson's disease. What's really great about rTMS is there's not a lot of side effects. So, the most common is transient headaches. And then people, because we're like putting a magnet against their head and it's pulsating, they say that sometimes they can have scalp discomfort or pain at that site. And then other people actually notice like when we're like dosing or when we're applying it, they get like a facial twitch. And then some people have syncope or pre-syncope. Very serious side effect would be if someone did have a seizure, but it's very rare if we're following the appropriate safety protocols, right? So contraindications are actually the presence of ferromagnetic or magnetically sensitive objects in the head or neck. So not in the mouth, interestingly. So if you have a gold tooth, you're good. So aneurysm clips, cochlear implants, deep brain stimulators. And that's because it's a pulsating magnetic field. Like interestingly, when we did our training, they were saying like if you had some other metal around your body, in contrast to an MRI, which is the constant field, we're not worried about that. It's more so located in the actual head. And then relative contraindications would be a history of epilepsy or increased risk of seizure, which I think if this was approved for alcohol use disorder, for example, or for like our stimulant use disorder patients, if there's a history of seizures, right? And then depending on medications, that may lower the seizure threshold as well for those patients. So just things to think about from an addictions perspective would be like, does someone have a withdrawal seizure? Is it remote? It's not necessarily a contraindication, right? So we think about things as very patient specific. And then, a combination of factors are people sleep deprived before they're going into treatment, high variable use of alcohol, abrupt changes in use before they go their treatments. And I think reviewing of medications as well, from my understanding, and again, I'm very new to this, we're just getting training ourselves, but My understanding is when people are receiving this treatment right now for psychiatric conditions, these are things that they're concerned about if people are like concurrent disorders and their use outside of that, if they're like if they're getting treatment for depression, for example, if they could trigger a seizure. So how does rTMS work? So just like most things in med or psychiatry, we have a number of different theories, but our current theory is, and one of the theories, and I won't get into the neurotransmitters, blood flow, things like that, but it's the neurocircuitry. So, what is a neurocircuit? So when we think about neurocircuitry in the brain, I like to think about it as like a house, right? So your house has a bunch of different electrical outlets. We have light switches, and they're all connected by wires. So in the brain, these are connected by neurons, and we have core key sites in the brain that we target and are responsible for different things. If we think about the neurocircuitry in addictions, we think about things like the go system was driving addiction, and then what would be there to stop it, like our executive functioning, to the stop system. In general, everyone has like a few different neurocircuits that are like we have a default network, which I won't go into, a salience network, and the executive functioning network, but they're all important for key elements of human behavior. So this is like the classic picture that's probably in Learning Hub modules around the world about like the neurocircuitry of addictions. So you can see they're like key, like, and this is like the brain model of addiction, right? So we look at different key structures that are associated with it, and then different neurocircuits that are involved or driving the different types of behavior, like thinking about withdrawal and negative affect being one system, which like we have associated with the amygdala, preoccupation and anticipation, which is associated with the anterior cingulate cortex. And then we have the binge and intoxication, which is associated with a number of things, including like the globus pallidus, right? But specifically in but specifically when we're looking at rTMS, a lot of the research focuses on the dorsolateral prefrontal cortex and thinking about that executive functioning network and strengthening the top-down control. So if we think about our limbic system as like our emotional dysregulation and things like that, essentially what they're trying to do is strengthen the control that it has over that. So that's kind of what this slide is talking about. And a lot of studies are also targeting the insula, which is a part of our like interoceptive system. So like monitoring our physiological states like internally and driving behaviors and including like cravings. Okay, so checking in, everyone's still awake. So now like talking about some of the evidence of rTMS and substance use disorders. I by no means am going to go into all the different studies. I'm just like touching on a few here and there. So there was a meta-analysis done in 2019 where they looked at randomly controlled trials. They looked at patients with nicotine, alcohol, and illicit drug dependence. And this was studies, they included the drugs were cocaine, methamphetamines, and heroin. The primary outcome they looked at was craving. So that was through self-report intake or relapse counts. And they also did a regression, to assess the influence of variables such as the substance type, the rTMS protocol, and total pulses. And I'll talk about it at the end, but a lot of the different studies, because it's still like an emerging field, don't have, they use different protocols, different sites. They're looking to see where they should, like how long and all those different things. So what they found is that there was a reduction in cravings with excitatory rTMS of the left dorsolateral prefrontal cortex. So that reduced cravings. That was significant. And when they did the meta regression, it was more for illicit drugs than nicotine than alcohol. What they found is that when they did inhibitory, and so like I said, when we do higher frequency, it lights something up. So it gives it more activity. But if we do inhibitory, so a lower frequency, it reduces the activity. So it's why we use different frequencies at different circuits. You want to uplift something or decrease something. They found that the inhibitory to the left and right dorsolateral prefrontal cortex and the deep rTMS had no effect. For substance consumption, they found that the excitatory rTMS to the left dorsolateral prefrontal cortex and excitatory deep TMS to the bilateral dorsolateral prefrontal cortex and insula showed significant reductions in consumption via sham. I should have said this a little earlier. Usually when they're doing the randomly controlled trials, they do bring them in and put them under like a sham device that makes like the machine, if you hear it, it makes like weird noises. So they bring them in and there's like a weird noise. I think sometimes they try to even stimulate some of the feelings they feel on the scalp and things like that. So, and then they found in terms of dose dependency that a meta-regression showed a positive association between the total number of stimulation pulses and larger effect sizes. So again, thinking about like dosing, is it the total number of sessions someone's receiving or the pulses that they're receiving? Something to think about. Okay. So essentially, this is just summarizing what I said, but this paper essentially said that the left dorsolateral prefrontal cortex, when we did excitatory rTMS, seems to be the most promising protocol for reducing cravings and possibly substance consumption. And then more pulses or a higher stimulation dose may increase the efficiency. And then deep TMS targeting the bilateral dorsolateral prefrontal cortex and the insula may reduce consumption. And so essentially, these findings suggest potential for rTMS as an adjunctive treatment, not necessarily like a standalone, especially in people who are struggling with cravings, right, or early relapse. Okay, so now we're going to move into one of the FDA and Health Canada approved indications, which is the H-coil for nicotine use disorder. So for nicotine use disorder, one of the studies that led to FDA approval was this study done in 2021. So it was multi-center, double-blind, randomized, sham-controlled. The inclusion criteria included chronic smokers, so they usually smoked at least 10 cigarettes a day for a year. They needed to meet criteria for nicotine use disorder, which I think makes sense. And they had to be motivated to quit via questionnaire. And they didn't want a history of abstinence for more than 3 months over the last year. So the intervention was deep TMS using that hairdresser style coil, targeting the prefrontal cortex and the insula regions. And they did daily sessions, so 5 days a week for 3 weeks, and then they did it once a week for 3 weeks. So everyone got a total of 18 sessions. The primary outcome was 4 weeks of continuous, I had to look this up. So it's essentially a 4 week continuous quit rate. So they gave them a few weeks where like they could still be smoking while receiving the treatment, but then they wanted to see people have cessation of smoking after the second week onward, and they followed them up to 18 weeks if they had a continuous quit rate at 6 weeks. And they also used its self-report and urine continine and biomarkers. Secondary outcomes, they looked at reduction in cigarettes per day, craving reductions, and safety. So the results in the intention to treat analysis, the deep TMS was higher than the sham. So it was 19.4 versus 8.7. The p-value is there. And those who completed the treatment, the active was 28% versus 11.7%. So it was significant. They also showed that the deep TMS had a greater reduction in cigarettes compared to the sham within 2 weeks of the treatment, and that deep TMS had a significant drop in craving scores, but there was no significant difference in withdrawal symptoms between them. This is just a slide to show you kind of the protocol. I think this is from the CMJ. So essentially, it's just week 1, week 2, 3, 4, 5, 6, and the treatments they received. What's interesting with the protocol right now for nicotine use disorder is they actually use a provocation before they deliver it. So they want to like activate the circuit. So they usually ask patients to think about smoking or essentially before they deliver it. And they do the same thing in OCD. So for OCD, when they're trying to light up that circuit, they try to get people to have some level of anxiety and to think about their obsession before they deliver it. And then they did the therapy for about 18 minutes and they had brief counseling. And this is just a diagram to show what we already talked about. So on the axis here, it's the continuous quit rate. And then here we have the intention to treat, and then the completers. At week 6, you can see there's a significant difference. And then at week 18, there's a significant difference, but more significant with the completers. Okay. So from this study, they showed that the deep TMS essentially significantly improved short-term smoking cessation and reduced cravings, and now it's approved for an adjunct aid in smoking cessation. And it kind of shows that proof of concept that non-invasive neuromodulation can target the addiction-related circuits. So something that I think maybe we'll see more literature around, or hopefully, because I think it's a bit of a gap, is how are we going to combine things like neuromodulations with already like psychotherapy, if it's, a psychiatric condition, or pharmacotherapy for things. So this was a study done in 2023 where they assessed the bilateral rTMS directed at the insula using the H-coil while people were also on Champax. So again, randomized, double-blind, sham-controlled. They used high-frequency rTMS directed to the insula for 4 weeks while they received Champax for a total of 12 weeks. And essentially, as you can see from the diagram, it was significant at 12 weeks, but this was not present at 4 weeks or at 26 weeks. So that's one of the things as well. Even with ECT or rTMS, it's with depression as well, it's the maintenance. How often would you need to give someone like a maintenance treatment to maintain the effect? Okay, everyone's still awake? Okay. So then thinking about future directions for substance use disorders. So not approved, but there are a lot of studies focusing on alcohol use disorder, stimulant use disorder, and opioid use disorder. It looks like, and I could double check this, but the majority, it seems like right now, a lot of, I think there's more for like more studies on alcohol use disorder, but they're all emerging and a lot of people are doing different studies. I had a slide at one point that showed how many studies that were currently ongoing, and there's quite a lot. So alcohol use and rTMS. So in 2020, this person did a meta-analysis and systemic review, sorry, of non-invasive brain stimulation alcohol use disorder. This one, they did actually include the TDCS as well. So they're just looking at the efficiency of both of these interventions in reducing alcohol cravings in people with alcohol use disorder. There were a total of 34 studies. 23 of those were about rTMS. So as you can see here, so the pooled effect size of the standard mean difference was not significant, but essentially they did see some potential reduction, a potential moderate reduction in cravings. But essentially, the individual studies showed mixed results. So some studies did report significant short-term reductions. Others showed no difference compared to sham. There's a lot of variability in the protocols, and that's like one of the limitations when you're doing these things. So some people used, left or right dorsolateral prefrontal cortex. Some use the medial prefrontal cortex. Some use high frequency versus low. There was a variable number of sessions. So essentially, like it's hard to say, right? So yeah. Okay. So just touching on another study. So thinking about when we looked at nicotine use disorder and the combination with Champix and, if that would be another form of treatment or something that we should consider when we think about alcohol use disorder, we obviously do have to think about what would it look like combined with medication management for alcohol use disorder. But I just thought this was interesting because of my background, that there was a study done in 2022 where they looked at its combination with cognitive behavioral therapy. Interestingly, we think cognitive behavioral therapy also modulates neurocircuits, right, and strengthens top-down control. So similar kind of way that we think these things work. So this study was randomized, double-blind, and sham-controlled. It was multi-center. They had 263 subjects included. They had six groups that they tested. Did not list out the groups because it's just a blur of letters. But essentially, there were different combinations of left or right, dorsolateral prefrontal cortex versus sham, and then a mix of like if they had fixed CBT and non-structured. So the intervention, if they received it, was rTMS 10 sessions twice a week. And the CBT, if it was a fixed plan, was eight weekly sessions. And the primary outcome was relapse at 24 weeks. So drinking again after detox. And they looked at, I won't touch as much on this, but the secondary outcome was cravings, dependent severity. They looked at cognition, depression, anxiety, sleep, and lab biomarkers as well. So the primary outcome results show that the highest relapse was in the sham with minimal CBT, and the lowest relapse was in the combinations with rTMS and CBT. And you can see here the relapse rates below. So I did throw this slide in last night, disclaimer. There is emerging evidence for stimulant use disorders and rTMS as well. So this study was done in 2022, and we're looking at the efficiency of repetitive transcranial magnetic stimulation in patients with methamphetamine use disorder. And this was a systematic analysis, and systematic review, sorry, and a meta-analysis of double-blind randomly controlled trials. They included 7. So looking at this briefly, they looked at craving reduction, and they showed that it significantly reduced craving compared to sham when they looked at the studies. And interestingly, because we're looking at so many different components of the rTMS as well, but specifically with methamphetamine use, they showed that intermittent theta burst stimulation, which is just a specific type that we do, 4 trials show that it had a significant effect. And then there were 2 trials that actually showed that the 10 hertz had a significant effect as well. So here's just a graph to represent that. So getting to the end. So thinking about limitations, which I think I've kind of sprinkled a little bit throughout the presentation, but when we're looking at rTMS and when we're looking at, you know, the studies and should this be approved or a future direction for addictions. One of the challenges I think that I've noticed from a lot of the different studies is that there's a lot of heterogeneity and then a lot of differences in the stimulation protocol. So it's hard to compare them because there's not a lot of consistency. Some studies have smaller sample sizes, and then a big thing is short follow-up. And so um, that's just something to consider. And then there's a lack of data regarding its effectiveness when combined with things like pharmacotherapy or psychotherapy. So things to think about if they could be either combined concurrently when you're treating or should be sequential. So somebody is treated with rTMS and then they start therapy afterwards, for example, or those types. So I think some future directions to think about would be like protocols, right? To see if we could establish a specific protocol for the treatment of these specific disorders, to look at its treatment in concurrent disorders. And there is literature around that. I just didn't go into it today. But so, for example, a lot of our patients have concurrent disorders, hence why I'm here. So like, you know, if someone has depression, for example, and they have treatment-resistant depression, the treatment of that plus the treatment of their underlying alcohol use disorder, their nicotine use disorder, those types of things. Um, and I also think like sometimes when we're targeting this circuitry, are we treating some of the things that might be driving the addiction? Like, for example, if they are depressed and we're helping improve the mood. Combination therapy, like I talked about, and then long-term treatment. So it's something that's still in psychiatry for treatment-resistant depression as well, is the maintenance part of things. Like, so like the relapse rates. And when I think from my understanding is that they're still establishing those things after the initial treatment, and then funding. So right now, my understanding is it's not funded. But interestingly, I think Redfish patients are not paying. So, but at Redfish, they do have this machine that they're starting to use and roll out for treatment. So, but right now, if you wanted rTMS, it would cost you. So something to think about. That was me. These are nice. This is the survey. How long do sessions typically last, and what are the kind of inclusion and exclusion criteria for people? Yeah, so yeah, so again, like they're the standard protocol. So they, I think the one for nicotine use disorder is like 18 minutes, but like, I think that they usually block off, don't quote me on this, like 30-minute or to an hour sessions for each patient. But it depends on like what protocol they're using and that there's like accelerated, there's a new, so thinking about it from you know, a depression model, they have like it is a prolonged treatment, like in terms of the number of weeks. Like I think they say it's 20 sessions now for treatment-resistant depression. And then I think they usually block off half-hour to hour blocks, but again, I'd have to double check that. Um, but they have like accelerated protocols, like Stanford just did an accelerated protocol where you would do a number of sessions in one day, actually. Yeah, so they said that like that's a big, and it led to like very quick approval in the States. It's just not approved here, I think. So but that would like expedite things substantially, right, in terms of treatment and from a clinic perspective. In terms of absolute contraindications, it's really the metal hardware in the head due to the pulsating magnetic field. And then relative contraindications are like the seizure risk, and then also like pacemakers and things like that. Yeah. Something that say it happens. Yeah. Very much so study that have seizure history from alcohol, would they be potentially excluded from some of those things? I think, and from my understanding is they're not necessarily excluded. It's just very patient specific. So for example, if they had a remote seizure, I don't think they're completely excluded. It's very kind of like, oh, it was one, there's a clear reason why it happened. And they like assess their risk at the current moment. But yeah, and then like if it was more complicated, my understanding is they'd likely consult neurology just to comment as well in terms of that seizure risk. But for the most part, that's my understanding is it's not an absolute contraindication if you've had like a remote seizure once, like treated or like don't have a history of epilepsy kind of thing. Does that make sense? Yeah. Yeah. Okay. Yeah. For the nicotine use disorder studies, did they exclude people that had comorbid other substance use disorders? Have to double check that. I had a slide on the exclusion. Anyways, I have to double check that and I can call you back. Yeah.
I know probably the population we see, but I don't see many people.
With just one, yeah.
You do, but
Yeah. Yeah, and I think like in a lot of studies, like for different things, like excluding people with psychiatric comorbidities or other substance use disorders is usually like a limitation because you're not really representing the patient population that we're treating, right? Yeah.
Thank you.
Yeah, thanks. Thanks for the question. Oh, thanks. Yeah.
Right, but in terms of the inclusion criteria for some of the studies that you brought up there, whereas like stability, housing, finance, like where, you know,
Yeah, I have to double check. A lot of them were doing like the randomly, like a lot of them were meta-analysis and systematic reviews that I was quoting. But I think that's also a good point of like thinking about the driving cause of addiction and to because I know that obviously thinking about like use, if we don't have those basic needs stabilized, it's hard to see if like those things would, be like a huge factor in someone's relapse or actually controlling those things. But I could double check and yeah. Yeah, exactly, exactly. And that's another thing with rTMS. Like for one, it's like paying for it, right? And then two, like the time commitment. That's like a big barrier. So like if we do have that expedited protocol, and that's specifically for depression, right? So I don't like even though like with anyways, but yeah, if we use like expedited protocols, then it would be a much less amount of time people have to dedicate to the treatment, right? But even with ECT, when we do it, like people typically are so sick that they're not working, to be honest, because it's something we're using as not first line in a lot of instances, or when people are really, really sick. So it's something that's like even in the maintenance phase of ECT, like you can't drive, you might not be able to go to work after. Like these things are things to consider, like in terms of practicality.
and this the first question you mentioned in terms of price, like the cost.
Yeah. I asked one of the guys at UBC who's the head of the neuro modulation stimulation lab. I can't remember. Do you remember, Isaac? You were in the lecture. Okay. I think
Like for sure, like,
yeah, like it's that, yeah. Oh.
oh.
I looked that up once. It's pretty expensive, I believe. Yeah. Yeah. But again, great questions. Because these are the practical things. Like if you're going to bring it into your own practice, for example, who's going to pay for the machine? And what's the patient population that it will benefit, right? Yeah. Yeah, we'll see. Yes, Dr. Haynes.
Your review, like where do you think this is going to be in about 10 years or so?
Yeah, I think it will be more a part of our practice than it is now, especially for psychiatrists, because it is currently in the guidelines, like the CANMET guidelines. And that's more, again, I know we're in addictions room, but just thinking about like it's progressing very rapidly for psychiatry. And like in terms of like now it's approved for OCD. And I think like one of the things next is going to be PTSD. For addictions. I do think like it looks like they're putting a lot of like there's a lot of research going into it, so it could be a part of practice hopefully soon because I think the more agents we have, the better, right? But again, like I think there are a lot of limitations in terms of like finding the right protocol, the right targets, right? Setting all those things in motion.